Hello, y'all. This is the last day of chapter 23 before we start chapter 20 tomorrow. So I figured I would just run through chapter 23, which is extraoral and digital radiography, one more time with everybody. Um, let's first talk about panos or panoramic, okay? So panoramic X-rays, which we all know, it is the radiograph that shows the entire maxilla and mandibular on one film, meaning it gets the entire dentition. It gets the upper teeth, the maxillary arch, it also gets the mandibular arch. It's everything. It's sinus cavities, eye sockets. You can see teeth that hasn't even been erupted yet, teeth that are in the budding stage, sinus cavities. You can see a lot in a pano. Um, just a couple things that the pano X-ray gives. Um, the pano X-ray gives the dentist and dental assistant a general view of the following: the entire dentition, nasal and orbital areas, alveolar bones, lesions, fractures, cysts, and tumors, malocclusion, maxilla and mandibular, sinuses, unerupted teeth, dental appliances and restorations, periodontal disease, and temporal mandibular joints, which is the joint which causes TMJ. Um, slide back a little bit. I kind of just want to do a couple of tips for y'all. Don't know if we went over too many tips in class, but tip one, remember to always have your lead apron. No matter what X-ray you're doing, you're gonna always have on your lead apron. Um, sometimes you might have to use a different kind of lead apron for certain X-rays, like with the panoramic X-rays. Sometimes if you use the one with the thyroid collar, which goes up the neck and snaps behind them, sometimes depending on the angle or the positioning of the head, it will actually show what we call a ghost image of the lead apron on to the panel, the actual film. In that case, you would want to get the lead apron without the collar, without the thyroid collar. That way, it'll just be a regular little strap. You can take the panel, and it'll never show up on the actual X-ray. Another thing that shows up on X-rays, um, metal. So whenever you're getting a patient set up for the panel, one of the first things you should just go ahead and always ask is if they have any metal that can be removed. So what I do is I ask, is there anything that can be removed from your mouth? Candy, gum, tongue ring, partial denture, any kind of metal. And is there any metal from your shoulder blades on up? Meaning chains that are metal. If they have like a big bulky jacket and it's buttoned up all the way, they're gonna need to take that jacket off. Don't really need anything too bulky that's gonna prevent the full orbit of the panel machine. Also, you don't want to get the ghost image of the actual button into the panel. Earrings, so it'll be your necklaces, your buttons, come on up. Any piercings, facial piercings, tongue ring, lip ring, that has to go, especially if it's metal. Definitely gonna show a ghost image. Um, Partial denture, yes, it's plastic or resin that you see, but most of the bases have metal in them. And if you take a pano or any other X-ray, it will show up in the X-ray. Um, what else? Like I said, facial piercings. And the reason why I said shoulder blades up is because if they have bobby pins in their head, then that will also show. Certain kinds of barrettes, like little kids or even adults, just make sure that there's not any metal. It will show up on the film, and it's what we call a ghost image. And the reason why it's called a ghost image is because you can't see it as clear as you will see everything else in the panel, but you will see it faintly. So it'll kind of be like a blurred image. So if a patient have earrings in, they have two earrings in, and they take the panel, you'll just see a blurry bright line that's going to go straight across the X-ray. Now, if the patient have earrings in and they're hurting on the top two, if you take that panel with the earrings in, it's gonna have that ghost image. It's gonna be a blurry white line that's gonna go straight across exactly where the earrings are positioned. So if the patient is having problems with the upper tooth, then there's nothing you can really see in the panel because you have a ghost image going all the way across. So make sure you take those out. Even earrings on the top of the ear, even though it's not in your direct line of smile, still gonna want to take them out because if you have the patient um, positioned too far down, it could definitely angle down into the teeth. And then sometimes if they are too far, it will angle on the teeth and have a ghost image. Um, let's see. Another thing, like I say, always ask like, do you have anything in your mouth that can be removed? Candy, gum, tongue ring, partial denture, and you want the candy and the gum gone too because if they have candy in their mouth, then they're gonna either constantly be sucking on the candy or chewing on it the entire time while taking the panel. Okay? While taking panos, as well as every other X-ray, but definitely a panel, the patient is gonna have to be as still as possible. It only takes about a minute and a half to 2 minutes for the full resolution of a panorama. They just need to be still for a minute and a half to 2 minutes, okay? So to nip that in the bud, just go ahead and no candy, no food, no gum. Get them to bite into the bite stick, and it'll be a groove at the tip of the bite stick. Get them to bite with their two front teeth, 8 and 9, or enough. Get them to bite directly on that little line, and it'll be a dip. It'll be a deep groove on the bite stick. Get them to place that top anterior on that groove. Once they get their teeth in the groove, I always tell them to hold as still as they can, keep their teeth in the groove, and smile as big as they can to show every tooth that they can possibly show. Okay, so they'll literally be like this. Okay, biting and smiling, right there. So whenever I get them to bite and smile, that's when I kind of make my last adjustment. That's when I really take a step back to see, okay, are they level? Do I need to bring their chin up a little, bring them down? And when you're adjusting, don't let them move. Tell them still, be as still as they can, and keep biting. But you will sometimes have to adjust up, down, and that'll be okay. So I get them to bite in the groove, smile as big as they can, and if they're down like this, then I'll slowly hit the button and slowly raise them up until their teeth are perfectly straight, with me at least. And I can't say with me because sometimes I have to squat down, with the shorter patients. Taller patients, I would have to, tippy toe. So it's not really directly with you, but you want it to be just as straight as possible, just looking at it. Every panel is not going to be perfect, but you need to shoot for every panel as well as every x-ray to be as perfect as possible. I mean, as perfect as you can get it. And if you cannot get the perfect x-ray, don't be afraid to go get another assistant or even ask your dentist. You're going to always want your x-rays to be as perfect as possible because your x-rays are what gets sent to your insurance companies or even whenever people are paying out of pocket, sometimes they want to see the x-rays. But especially for people with insurance, the x-rays is what gets procedures approved. Okay. So if you take an x-ray and it's like half cut off or it's too blurry, not enough root, not enough of the actual clinical crown portion of the tooth, then it can get denied. Some treatment doesn't have time to be denied. If a patient is coming back to get a root canal, they don't have time to get denied, have to come back to the clinic, take more x-rays, get sent off again for another 2.5 weeks maybe, for them to get approved. Then once they get approved, then they have to be put on the schedule, which could be another month, a month and a half before we even see them. Cases like that, we don't have time to wait. A patient who needs a root canal needs to get in and out as soon as possible. So X-rays are gonna have to be immaculate. And that isn't to scare you or discourage you from anything. It's just to make you better. You want your X-rays to be the best X-rays out of your clinic. Okay, um, that's just a goal that y'all all need to strive for. Another thing that I'm going to talk about is the extraoral radiographs, which is the bite wings PAs that we've already taken, but here in class we've used the wall unit. Okay, um, the digital X-rays are not the wall unit. So what it is with the digital X-rays, you have your sensor, and then you have a sensor holder, and then you have a nomad, which is kind of like a humongous looking gun, but it's an X-ray gun. Okay, and we don't have it here, so I'm gonna pretend. Let's pretend this is your sensor, and so you replace it the same way that you would with the wall unit. Place it directly behind that tube that you're gonna want to get the X-ray of, and with the nomad, you're gonna come in and angle it to however your sensor is angled. So you will still use the same sensor holders. You still use the red for the bite wing, the blue for the anteriors, and the yellow for your posterior teeth. Um, but with the wall unit, whenever you take the X-rays, you have to actually develop it. Okay. Sometimes it's a two-step development process. Sometimes it's a three-step development process. But with the development process for the wall unit, you will take your X-rays, take your PA, bite wings, whatever you're gonna take. Then you're gonna get the actual film out of the holder, take it into the dark room, if you guys have one. You take it into your dark room, which is normally like a little dark supply closet with no light in it. Um, then you would go developing, which um, all the ones I've used, they've been 25 seconds to 30 seconds per developmental stage. So with the one that we currently use, the first stage, 25 seconds to 30 seconds, you'll hold it in the liquid. It's, like I say, completely black. You either have a blacked out room, or you'll have a kind of like a little box apparatus that you have to stick your hands in. No light can go in or out, and you have a red top that you can kind of semi see through. Um, can't really see much, not gonna lie, but you can see just enough that you can actually be able to move your film to your different dipping stages. So it'll be first stage would be holding it in 25 to 30 seconds. Next stage, 25 to 30 seconds with no pauses, just back to back, okay? And the next stage, 25 to 30 seconds. If you do 25 seconds on the first one, try to do 25 on all of them, vice versa. If you do 30 on the first one, do 30 in all of them. Well, that's with the wall unit. With the digital radiography that I'm talking about, you don't have to develop film, so to say. As soon as you shoot that nomad, as soon as you pull that trigger the second time, the picture will automatically start transferring into your computer. Okay, it's all digital. So shoot the nomad within 5 to probably 8 seconds at the most. It'll be already popped up on your screen. Um, that has a lot of advantages when it comes to saving time, um, even wasting time. Uh, Most offices nowadays do use digital, but in cases where the sensor goes down, normally the backup plan in the office is to have the old school volume. They're great to know. It really is. What else? Like yeah, like I said, you still use the same ones. With the digital, it goes straight to the computer. That way, if you mess up, you can automatically take another one. You don't want to take too many, but at least with the digital, if you mess up, you instantly know you mess up, and you can go ahead and take another one. With the wall unit, if you mess up, you're not gonna know that you messed up until you develop, in all of your stages, which takes about 2 to 3 minutes after everything is all said and done. But uh, if you did mess up, then you'd have to go back in and do the same thing, which would be taking the patient back in there, sitting them back down, putting the apron back on, getting everything set up again. And it's just a lot of time. It's time consuming. So, like I said, you want to get every x-ray pretty perfect. What else did I have? We also need to talk about positioning of the head when taking x-rays. Most of the time I'm talking about pano whenever I'm saying like the angles of the heads. That's something that I would rather just talk to y'all in person about it, that way I can actually show y'all on each other. As far, I want to try to get y'all all to come to my office one day so we can work live with X-rays, so that I can actually show y'all live about different positionings of the head, different angles for everything, as far as the angle of the nomad gun, the angle of the wall unit, the angle of the actual sensor that's going in your mouth. So we tried to get on that pretty soon. Hopefully tomorrow we can touch bases on it. Another thing with the angle is whenever you're taking a panoramic, your angles have to be good. If you get the patient to bite and it's too far down and their head is like this when you take it, then the X-ray come out with a little smile. And dentists really don't like that smile. That's the one smile they don't want to see, is the smile on the panel. And if the patient's head is up too high, then the X-ray will go down a little. Again, they really don't want to see that. You want all of your panels to be as perfect as possible. This one is not a perfect panel, but it is one of the closest panels to perfect. Like if you don't know much about panels, you would think that's a perfect panel. Okay, but it does have a slight curvature towards the ear, towards your back molars. There's like a slight little curve, and that's okay. If you get that curve, that's fine. You know, you just want it to be straight as possible though. Um, Yesterday we talked about, well, we talked more about when you would use PAs versus fly wings versus panos. Um, I want y'all to keep going over there. And tomorrow we will have some more scenarios like we did yesterday, where y'all have to tell me if you're going to use a pano, you're going to use a PA, or if you're going to use a bite wing. So keep going over those. Also, look at your landmarks of your skull, which that was a chapter or two ago. But whenever you are taking X-rays, that's where your landmarks are gonna come in play. That's why I said when we went over that part, it seems like it has nothing to do with dental, but eventually it would kick into play. This is the chapter where it comes into play. Okay, if you can know your landmarks of your face, most 9 times out of 10, you'll be able to take the perfect panel every time because you'll know how their face should be in order for that panel. Okay. Again, that's something that I'll have to show y'all in person to make it really clear. Don't really worry about that too much right now. Let's see. Conditions or artifacts that may appear on X-rays. And when I say X-rays this time, this is talking about panos, bite wings, and PAs. So conditions or artifacts that may appear on X-rays. Dental caries, implants, impacted tooth, recently extracted tooth, root canals, periodontal pockets, orthobands, overhang, which is with crowns. We'll talk about that too. Calculus, attrition, abscess, cyst, vertical bone loss, eyeglasses if they don't take them off. That's another thing. You have to get them to take off their glasses. And some patients be like, I can't see without my glasses. That's okay. We don't need you to see it this part anyway. We're just trying to see your teeth, okay? They don't need to see. If anything, tell them to close their eyes. That way they don't have to look. I do tell my patients to close their eyes with the panel machine. Like I say, the panel revolves around your head. About 3 to 4 times it's gonna go around your head. Sometimes patients will be biting and then they'll see it coming and they'll turn their head and then they'll try to follow it. If they move, you're gonna have to take that panel over. So if you want to tell them, go ahead and close your eyes anyway, perfect. I do myself and it works. I'm not gonna say perfect every time, but 9 times out of 10, it's gonna be a perfect panel. Another thing that may appear on the X-ray is amalgam shavings, vertebrae, metallic restorations, fractures, and that's fractures with the teeth, with the bones, mixed dentition, which is primary and permanent teeth, all in the same mouth at one time, abrasion, drifting, supernumerary teeth, horizontal bone loss, bridges, earrings, which bridge you could be up in there because the bridge is permanent. Earrings should not be in there. Cements, root canals, pins, and framework for reconstruction jaw surgery, which would be actual screws and pins will be in the jaw. And it'll show up on the panel, and that's okay. Sometimes it might even throw a ghost image on the panel. That's okay. There's nothing you can do about that in that situation. So don't let that one get you down either. Um, I think everything else would have to be an in-person thing, y'all. We are going to talk more about the sensors, which I know we have before, but I just want to get y'all to really grasp the concept of the sensors versus the wall unit. So we'll talk more on that tomorrow. I still want y'all to continue to look over X-rays. So panel, bite reading, PM. Sorry. Keep looking over those. Remember your colors: yellow, blue, and red. Okay. Red, bite wing. Blue, anterior, the front, and yellow is the back posterior teeth for the PA. Okay. So y'all just plug that in. Remember that. We will be going over that a lot tomorrow. Uh, Actually, we won't go over it a lot. It's kind of going to have to be a quick thing because tomorrow we're starting chapter 20. And chapter 20 is anesthesia. So we're going to talk about it, but we're not going to spend the whole night on x-rays anymore. But just please continue to look at all of that. And I will be able to show y'all. Oh, look, I found a nomad. A picture of a nomad is on page 560, figure 23 through 25. And it says a handheld dental intraoral radiography machine. That's going to be your nomad, which that's an older one, but it would be a nomad. And if you want, you can look up some YouTube videos. I could send y'all couples. You can really see what I mean, what I'm talking about. If not, I'll have everything ready for y'all tomorrow as far as x-rays go. And after we go over x-rays a little, then we will start chapter 20, which is anesthesia. Um, so this is the end of chapter 23. Y'all have a quiz tonight. I hope everybody gets to take it. I hope y'all all make 100 on it. I'm rooting for y'all. And I am excited to start chapter 20 with y'all tomorrow. We won't be using live needles on each other, anything. It's not going to happen, okay? But we will be working with actual syringes tomorrow, okay? Nothing dangerous. We won't even use a needle. It's just going to be the syringe. So make sure y'all are here tomorrow. We're going to show y'all some tips on passing the syringe, taking the syringe back, uncapping it, capping it, and getting everything set up as far as the syringe go without a patient realizing it. Because when you're working, I mean, kind of with anybody, you don't want them to see the anesthesia getting ready. But especially with kids, you do not want a child to see a syringe. So we're going to work on that tomorrow. We're going to work on setting up the syringe without a patient noticing or seeing, handing off the syringe without the patient noticing or seeing, and also capping it without them seeing it. I try to never let my patients see a syringe or a needle. Never. Okay. So we will start chapter 20 tomorrow. I hope y'all have a great night. And if y'all need anything, shoot me a text or call me, and I'll either jump back on Zoom with y'all or I can send y'all some videos. All right. Thank y'all.